So, good evening, ladies and gentlemen, friends all across the country and the globe. Uh, we are here for the fourth session of Freedom Series, which is a joint series between Indian Academy of Neurology and Association of Physicians of India, which was started on 26th of January 2022. There has been a great success on this front, and we have been very happy to take it forward, have a one session every month ever since January 26th. And today's session on Parkinson disease has been on the demand of many of the physicians, particularly from governing body of API, who felt that Parkinson should be discussed in detail with them. And with keeping that in mind, I have uh, organized this as a Parkinson disease series for today. And we have great speakers uh, on this field, and you got all those who are here. They are one of the expert in movement disorder and Parkinson disease. So I'm sure this is going to be a very interesting and a useful seminar, and I'm sure all of you would be benefited. Those who missed out on this session, they can go on to the YouTube and have it even after the session. So that will be available on the channel of Indian Academy of Neurology YouTube. Now, important thing is, rest all people are around. We got this series was initiated by the effort from Dr. P.K. Maheshwari and Dr. Gagandeep Singh. They are the coordinators between the IAN and API. And today's moderator is Dr. Achal Srivastava, who is the EC member and also has been the past chair of movement disorder subsection of the IAN. The speakers are Dr. Charu. He was a past president of Movement Disorder Society, the present secretary, and Rishikesh Kumar, the Sanjay Pandey, and the past president, Indian Academy of Neurology, Dr. Pramod Pal, and current secretary, Gagandeep Singh. I'm sure the chairperson are going to introduce them in very detail. But the most important thing is, what has changed is, today we have new president of Association of Physicians of India who has joined, and I welcome Dr. Shyam Sundar to this series. The first three series we had with Dr. Tiwari, and Dr. Shyam Sundar has taken over at Jaipur last month, and therefore this is a very important session as he has been very much here. Dr. Shyam Sundar is distinguished professor of medicine, IMS, BHU, the Banaras Hindu University, Varanasi. He has a lot of fellowship, Indian National Science Academy, Indian Academy of Science, National Academy of Science, National Academy of Medical Science, and World Academy of Science from the Italy. He has many awards, more than 46. I'm sure you name them, the 2 hours will go into that. But these are some of the important awards which he has received, like Anna Maria Chesini 2010 award in Geneva. He has many other awards from India also, from the President of the Republic of India, Visitors Award, Ambedkar Centenary Award, Ranbexy Science Award, and Goel Prize. He has several research grants, about 65 crores, and he has H index of 97 and citation more than 38,000. So truly a scholar who has been here. So I welcome Dr. Shyam Sundar, and Dr. Shyam Sundar, we would like to hear from you before Dr. Maheshwari take over and Gagan take over and pass on. Dr. Shyam Sundar.
Thank you, Dr. Surya, for the kind words, and thank you for the invitation. It's really a great, I'm delighted to be here in the joint IAN and Indian Academy of Neurology and the Association of Physicians of India venture. You know, I mean, every physician or internal medicine person comes across neurological diseases quite often. And this disease, Parkinson's disease, I mean, it is I understand there are 1 million patients in the country, and this is only second only to the Alzheimer's disease as far as neurodegenerative diseases are concerned. It is very important to know that, I mean, since this is an incurable disease, at the moment we don't have any cure for it, but there are several drugs which can be helped in relieving the symptoms of the patient. There has been quite a number of advances in the management of Parkinson's disease, and I am sure our members of Association of Physicians of India as well as Indian Academy of Neurology will benefit the most. With these few words, I wish the Freedom Series a great success. Thank you very much.
Thank you, Dr. Shyam Sundar, and we look forward to have a regular series with you, and I'll come back to you. And with that note, I request Dr. P.K. Maheshwari and Dr. Gagandeep Singh to kindly take over the session and introduce the chairperson who can take further, the coordinator of the series.
Thank you, Nirmal, and thank you so much. It's such a great pleasure that the two presidents, both of the Association of Physicians of India and the Indian Academy of Neurology, Dr. Shyam Sundar and Dr. Nirmal Surya are here. We are extremely grateful to you both for this important initiative, which I think will go a long way in bridging the treatment gap and improving the lot of people with Parkinson's disease in our country. So with this, I pass on the stage to the floor to my dear friend and colleague, Dr. P.K. Maheshwari, who is very, very active in both in the API as well as the Indian Academy of Neurology, and he will introduce the chairpersons, also the topic, and then the proceedings can be taken over. So, Dr. Maheshwari, please.
Thank you, sir. It's my pleasure to introduce our chairpersons and the moderator. Slides. Dr. Ravi Yadav as chairperson, and Dr. Sanjay Pandey as chairperson, and Dr. Achal Srivastav as a moderator. Dr. Ravi Yadav is a professor of neurology and very well active in movement disorder in Bangalore as well as in India. And also Dr. Sanjay Pandey in Delhi, he is very much active. And our dear friend Dr. Achal Srivastav, he is going to moderate the session. Now we should not involve in the lot of the time and pass on to our chairpersons and the moderator.
So I thank Dr. Nirmal Surya and Dr. Shyam Sundar and Dr. P.K. Maheshwari and Dr. Gagandeep for their kind introduction. And I will have few lines about Dr. Shyam Sundar because I did my MD medicine from IMS BHU, and he has been my teacher, and I pay my regards to him. He is a very passionate teacher, and we were all very excited when you knew that he has written a chapter on Kalajar in Harrison's textbook of medicine. So he is a very, very inspiring teacher and very, very motivating teacher. And still we derive a lot of motivation from him. And I pay my sincere regards to Dr. Shyam Sundar. And on this note, I will welcome my co-chair, Dr. Ravi, and my moderator, Dr. Achal Srivastav, who is going to moderate the session. And for this session, Dr. Charu Lata Sankla is the first speaker, and she is going to speak on what is Parkinson's disease and its symptoms. And before I call Dr. Charu, I will introduce her that She is a consultant neurology at PD Hinduja Hospital, and she has been a very, very dynamic force as far as Movement Disorder Society of India is concerned. She is, of course, the past president, but she has been a motivation for all of us and a driving force for Movement Disorder Society, like in last 1 decade I have seen. And I will also like to have an advertisement regarding the coming MDSI conference. And I request everybody to get registered if they have not registered till date. And this conference will be happening from 12th to 15th of May. And Dr. Charu Lata Sankla is the organizing secretary for that. Welcome, Dr. Charu.
Thank you. Thank you. Thank you for that kind introduction. So, shall I start my talk?
Yes, Dr. Charu. Please
Yeah.
go.
Let me just. And my slides are clear, right?
Yes, ma'am.
Yeah. So, today my objective of my talk is going to be the recognition of the motor and non-motor symptoms of Parkinson's disease, to discuss the clinical stages of Parkinson's, understand the challenges faced in assessment of the clinical symptoms, and highlight the fluctuation of the motor symptoms in the Parkinson's disease. What is Parkinson's disease? Now, the Movement Disorder Society, which is an international society which has led the diagnostic criteria for PD to make everyone's life a little easier to see what is Parkinson's. We now know that Parkinson's disease has a lot of facets, and it is more like a syndrome rather than just a single clinical entity. There is a UPDRS scale that we use uniformly, all the movement disorder specialists use. This scale is very easily available on the net and can be accessed by all the students. So what is Parkinsonism? The motor Parkinsonism is an essential criteria for the diagnosis of Parkinson's disease and requires both of the following. That means you have to have either bradykinesia or rest tremor or rigidity. So the second is or, but the first one is a must for all the symptomatology. So in Parkinson's disease, the movement is significantly slowed, but so is movement is slowed even in the pyramidal disease as well. So how do you differentiate between the two? There is a decrement in the amplitude and speed when you ask them to tap the fingers. So that means when you start with tapping of the fingers, the amplitude of the tap is larger, and as the 10th tap comes, the amplitude starts going down, and there are times there are hesitations and halts in the finger tapping. Rest tremor is 4 to 6 hertz tremor. It's a very coarse tremor and usually observed when the patient is not paying attention or is giving you the history, or the patient is walking and not looking at his limb. So this is in the fully rested limb, and it is usually suppressed when you ask the patient to raise his hands and hold it for a while. The rigidity, as all of you know, is a resistant to passive movements of the major joint, and it is best elicited when you ask the patient to move the other hand's joint, and you are looking at the, suppose you are looking at the right hand, then you ask the patient to move his left hand, and that's when the rigidity, which is very subtle, can be brought into the play. What are the supportive criteria? These are the main criteria that we have looked at. What definitely helps you diagnose the typical Parkinson's disease and separates it from atypical Parkinsonism is a benefit to dopaminergic drug. That means when you give a dopaminergic drug to the patient with Parkinson's, there's a significant benefit. The response is dramatic, and there is almost 50% reduction in the UPDRS scale if you are using the scale. Normal to near normal level of function can be achieved on a single dose of dopamine in the initial stages of Parkinson's disease. The improvement with increased dose is noticed, and marked worsening with the decreased dose is also seen. So if the patient misses the dose of a dopamine, then you may see a significant amount of worsening in his Parkinson's symptoms. This may not be very evident in the early PD, but definitely becomes more evident as the PD progresses. If you see unequivocal or marked on and off fluctuation, that means you've given the dose of Syndopa or dopamine, and that the patient gets the benefit, and the benefit lasts for 3 to 4 hours, and then there is a wearing off of the benefit. That is called off fluctuation. I'm going to be showing you various videos to define these states of on and off. Predictable end of dose wearing off, presence of levodopa-induced dyskinesia, rest tremor of the limb, usually unilateral at onset, presence of olfactory loss or cardiac sympathetic denervation on MIBG scans. These are again the supportive criteria for the diagnosis of the Parkinson's disease. What are the red flags? What should alarm you from moving away from the diagnosis is progressive gait impairment. Or if there is a complete absence of progression of the motor symptoms or signs over 5 to more years. Early bulbar dysfunction, difficulty in swallowing, difficulty in speaking, early dysphagia within the first 5 years. Inspiratory, respiratory dysfunction, either diurnal or nocturnal inspiratory stridor or frequent inspiratory sighs. If you see this, then you know that you're dealing with what is not, we call the idiopathic Parkinson's disease. What are the other red flags? Severe autonomic failure in the first 5 years of disease, that is orthostatic hypotension, decrease of the blood pressure within 3 minutes of standing by at least 30 millimeters in systolic blood pressure or 15 millimeters in the diastolic blood pressure. Severe urinary retention, urinary incontinence in the first 5 years of disease should again raise the alarm in your head that you're not dealing with a typical Parkinson's disease. Recurrent falls, impaired balance in the first 3 years of onset, more than once a year, will again, we will think of atypical Parkinson's disease. Disproportionate anterocollis, that means bend forward neck, contractures of the hand, that is a striatal hand deformity, curling of the toes in the feet within the first 10 years should also raise the alarm. Absent common non-motor features in 5 years. Parkinson's disease is associated with sleep dysfunction, sleep maintenance, insomnia, excessive daytime somnolence, symptoms of REM sleep behavior disorder. If we don't see these symptoms, then one should start wondering whether we are dealing with the typical Parkinson's disease, because these symptoms are not seen in the tauopathies. These symptoms are commonly seen in the synchronopathy, which is a Parkinson's disease MSA. Autonomic dysfunction, constipation, daytime urinary urgency, symptomatic orthostasis. Loss of smell or psychiatric dysfunction such as depression, anxiety, and hallucination. If you have unexplained pyramidal tract signs, hyperreflexia with extensor plantar response, isolated extensor plantar response, should not completely rule out the Parkinson's disease. And when the symptoms are very symmetrical, Parkinson's disease is a asymmetrical disease. It is usually more prominent in one side and less prominent on the other side. So if you see the bilateral symmetric diseases, then you start wondering whether you are dealing with drug-induced Parkinsonism or something different like MSA. What are the absolute exclusion criteria? When you see them, you do not diagnose this to be a typical Parkinson's disease. Unequivocal cerebellar abnormalities, downward vertical supranuclear gaze palsy, or slowing of the downward vertical saccades. Severe variant of frontotemporal dementia, that means they start with the abnormal behavior, or primary progressive aphasia within the first 5 years of the disease. These indicate tauopathy.
Okay, I've found this on the web for isolated extensive planted response. We should not completely rule out the Parkinson's disease, and when the symptoms are very symmetrical, Parkinson's disease is a.
So I came down to defining the off periods and on periods. So off period is when there is severe rest tremors, which I described, which are 4 to 6 hours per second. And you can see there's a paucity of the spontaneous movement. He doesn't have any spontaneous movements like shaking his legs, brushing his hair, moving his hands. He's absolutely still. That suggests it's a bradykinesia. This decrementation in the amplitude starts with the amplitude and then it goes down. Okay, see. Okay, now you can see it. He starts with a bigger amplitude and then he starts getting the hesitations. And this is his walking. Reduce arm swings on both the sides. And you can see the rest tremor becomes very evident when he's walking, particularly in the left side. There's a gross asymmetry of his illness. Left is definitely more affected as compared to right, but he has bilateral disease. So these are the features that I just described in my presentation. Then you look for the postural stability. How do you look for it? You stand behind the patient and give him a gentle push. Don't push him till he falls, and then he is not able to hold his balance. This is suggestive of a postural, poor postural stability, which is again the hallmark of the Parkinson's disease. Now we have given a dopamine drug to this patient and see what difference happens, improvement in his clinical symptom. You can see the good arm swing. His gait is erect now. He's able to turn swiftly. There's a good stride length in his legs. And this remarkable improvement with a single dose of dopamine again helps you diagnose Parkinson's disease. The amplitude is improved, although not completely. Starts with a higher amplitude and then starts going down still, but he's almost near normal. And this is what we expect after giving the dopamine dose. And as an on period of the Parkinson's disease. But sometimes the Parkinson's disease progresses and we start getting dyskinesias as the dopamine dose requirement increases. And then you start getting what we call unwanted movements, motor movements. They are known as dyskinesias. And these are the non-troublesome motor deposits. Hand is moving in the choreographed manner. These are the choreographed dyskinesias which come with the levodopa, that are excess unwanted movements. They can become worse and they become troublesome. See this patient, he has to lie down when he gets this severe dyskinesias. He's unable to tolerate them. He gets breathless during his dyskinesias. Freezing of the gait. This is again a phenomena that we see in the Parkinson's disease. Usually the Parkinson's patients have difficulty in starting his gait. We call it start hesitation. And when they're asked to do these difficult maneuvers, then they tend to get stuck. See, that's what happens. That's called freezing of the gait, sudden interruption of the gait. We call it freezing, and this comes into advanced stage of the Parkinson's disease. So what are the stages of Parkinson's disease? So the prodromal Parkinson's disease now we are increasingly getting aware of. Why is it important? We need the drugs which can stop the progression of this disease. And they're best tried in this particular state of the Parkinson's disease. So if the patient has REM sleep behavior disorder, constipation, depression, hyposmia, and anxiety, these are the preceding features before the motor symptoms come into the play. These are some of the symptoms that you may see in the patients with the Parkinson's disease. What is an early stage of Parkinson's disease? I explained to you bradykinesia, rigidity, tremors, mild cognitive impairment, a little bit impairment in the planning, little bit impairment of the judgment of the distance. They don't sit properly in the chair, right in the center. They tend to miss the center of the chair and sit at the corner. Apathy and fatigue may be seen in the early stages as well. The mid stage of Parkinson's disease is associated with fluctuations, which I just showed you, marked on and off fluctuation. You can see the dyskinesias, which are troublesome in the initial, non-troublesome in the initial period, and they become troublesome as the disease advances, urinary symptoms, orthostatic hypotension. And once the late stage of Parkinson's disease comes, we start noticing the postural instability, gait disorder, frequent falls, dementia, and drug-related adverse event, and subsequent death. So we have a scales which tells us at what stage the Parkinson's disease is. This is a original Hone and Yard scale, which is extending from 1 to 5, which has been slightly modified to include 1.5 and 2.5 in the new scale. So 1 is unilateral involvement, 1.5 is unilateral and axial involvement, 2 is bilateral involvement without the impairment of balance, 2.5 is mild bilateral disease with the recovery on the pull test, 3 is some postural instability and physically independent, 4 is severe disability but still able to walk independently and needs some help in the activities, and stage 5 is wheelchair bound or bedridden unless aided. We talked about motor symptoms of Parkinson's disease, but now we are really aware of the non-motor symptoms of the Parkinson's disease because they decide the quality of life, progression of the disability in Parkinson's, cause of nursing home placement in Parkinson's, frequent admissions in our scenario, and chief therapeutic challenge in advanced PD. non-motor symptoms may not have effective treatment option, and we are going to look at few of them. So we divide them into the mood disorders, cognitive disorders, medication-related disorders, autonomic dysfunction, sleep-related wakefulness. These are the main non-motor symptoms that we look at. So in depression, we have mood disorders, anxiety, apathy, and fatigue. Cognitive dysfunction and dementia is seen as the disease advances. We do see psychosis, sometimes early also in the disease. Medication-related impulse control disorders are seen, and other compulsive behaviors are also seen in patients with Parkinson's disease. Autonomic dysfunction presents in the form of orthostatic hypotension, sexual dysfunction, gastrointestinal dysfunctions such as reduced motility, constipation, cyalorrhea, which results in drooling and excessive sweating. Disorders of sleep and wakefulness are REM sleep behavior disorder, sleep fragmentation and insomnia, daytime sleepiness, and sudden onset sleep episodes during the daytime. And they also have obstructive sleep apnea. We still don't know the basis of the non-motor symptoms in PD, and hence it becomes very difficult to treat them. And the treatment options are limited given the high prevalence and adverse impact of these particular symptoms. Motor symptoms in the PD are treated successfully with proper drugs, deep brain stimulation. We have now apomorphine pump, and we have a intestinal gel that is available. So we can take care of the motor symptoms of the PD. But what we are now facing the problem is appropriate treatment of the non-motor symptoms in Parkinson's disease. Coming to the cognition, the patient will complain of mild memory disorders, but memory disorder is not the hallmark of the cognitive decline in the Parkinson's disease. It's a visual spatial skills that are more impaired. It may also present initially as a depression, apathy, disinterest in taking part in the social activities, or frank psychosis. Neuropsychiatric non-motor symptom includes anxiety, apathy, depression, and dementia. And anxiety and depression can be seen as a premotor. That means before even the motor symptoms of Parkinson's begin. Psychosis is a symptom which makes it very difficult for the spouse and the other relatives to take care of the patient. And this is the cause of frequent hospital admissions. We don't have the nursing homes in India, but this is the cause of the frequent hospital admissions in our scenario. Depression causes a significant negative impact on the quality of life in PD, and it runs parallel with the motor symptoms as well. The patient with the PD is worried about his illness, is worried about his dependency as well. Excessive daytime sleepiness. This is seen in half of the patient. This is involuntary dozing. They doze off while watching the television or while doing the monotonous activity. PD patients also complain of poor concentration and poor memory because of the excessive daytime sleepiness. And this has also resulted in the road accidents or accidents at work. There are times PD patients have been falling asleep while working on the machinery or while driving. This concept of flip-flop switch being responsible for the sleep-wake cycle gets destabilized with the dopaminergic dysfunction. And that is why there is a rapid transition from excessive sleepiness to insomnia. And they fall asleep within the drop of the hat. And that is a little dangerous, particularly when they're handling the car and various machineries. REM sleep behavior disorder is very interesting feature of Parkinson's disease and can be seen in very early stages or even in the premotor stage. It's a parasomnia. Patient physically enact their dreams, vocalizations, and abnormal movements are also seen, and that can make it very difficult for the bed partners to sleep with them. They precede the motor symptoms in almost 40% of the patients, and 45% of the patients, when followed up over the long period of time, develop neurological disorder, have a higher prevalence of developing the neurological disorders such as PD, particularly syncytopathies. Nocturnal NMS, PD patients universally have sleep disturbances. That could be because of the rigidity, because of the bradykinesia. They may have poor sleep because of anxiety and depression, as well as because of the various dopaminergic treatment. There is a frequent increased frequency in the night in Parkinson's disease, and occasionally they may bedwet themselves. Severe kinesia makes it very difficult for the Parkinson's patient to turn in the bed, and they have to ask their spouse to help them turn in the bed. And that can also be a problem in falling asleep. They may have restless leg syndrome causing frequent arousal. And what is less stressed upon is obstructive sleep apnea in Parkinson's disease. and this is not associated with obesity. So one must look for a obstructive sleep apnea in these patients when they are particularly falling asleep during the daytime. A narcoleptic pattern of rapid sleep onset is also an important cause of sleep-related morbidity in Parkinson's disease. Sleep onset insomnia, sleep maintenance insomnia, that is difficulty in maintaining sleep, are very common in Parkinson's disease, and there's a reversal of sleep pattern. They tend to sleep during the daytime. They frequently doze off during the daytime and remain awake in the night. Constipation is a very prominent non-motor symptom in Parkinson's disease. Sometimes they are very obsessed about it. It may precede the development of PD by up to a decade. And this is the study that showed that when 6,790 men were observed, those with constipation had threefold risk of developing PD. Symptoms such as constipation, abnormal salivation, dysphagia, nausea are very common in PD patients and in controls. And it does not respond very well to the dopaminergic treatment, suggesting non-dopaminergic mechanism is the pathogenesis of these particular symptoms. Half of the patients with PD have orthostatic hypotension. We always associate orthostatic hypotension with multiple system atrophy, but we know that orthostatic hypotension is noticed in 50% of the patients with PD. Patients with postural stability are at the greater risk of orthostatic hypotension, increasing their risk of falling and injuring themselves. Postprandial hypotension is very common in Parkinson's disease and is usually associated with midday meals. So it is always advisable to give them small, frequent meals. Orthostatic hypotension can be a side effect of dopamine agonist as well as dopaminergic drugs, as well as a manifestation of the disease. Urinary complaints problems. When we did a study of non-motor symptoms in our cohort of patients, we realized the urinary problems were the commonest commonest non-motor symptom in patients with Parkinson's disease. They have dysfunction of the bladder as well as the dysfunction of the urethral sphincter muscles. So both bladder muscles as well as urethral sphincter muscles are affected. The other causes of outflow obstruction is prostate enlargement, and this should be ruled out in the patients with Parkinson's disease, particularly when they have difficulty in voiding. The commonest complaint is nocturia, and this is followed by frequency and urgency of micturition. 62% of the Parkinson's patients complain of nocturia. There's a polyuria in the night, urinary hesitancy, and urgency, which may cause accidents. This is embarrassing, but has very good treatment, which I think our next speakers are going to address too. Incontinence is a common reason for nursing home placement. Nocturia can result in the falls. If nocturia is combined with poor control of Parkinson's symptoms in the middle of the night, this is a deadly combination which can result into the falls, particularly when the patient attempt to go get up to urinate and they're rushing to the toilet. Detrusor overactivity is very common in PD and can translate into the urinary urgency. They also have difficulty in voiding. They need to also strain for voiding, and this may be because of the disorder of the bladder contraction or abnormal sphincter action caused by the bradykinesia. Fatigue, again, ignored symptom of Parkinson's disease, and it's very common. Obviously, negatively impacts the quality of life. It may be related to the other non-motor features such as depression, sleep, dementia, and it can independently present without having depression, sleep disturbance, or dementia as well. We do not ask about sexual dysfunction in Parkinson's disease, but we know that this is also a very important non-motor symptom which should be addressed by the physician who is treating patients with Parkinson's. Reduced sex drive has been reported in PD, and it is thought to represent another dysautonomic symptom of the disease. Testosterone deficiency has been implicated in this process, and testosterone replacement therapy sometimes improves motor as well as non-motor symptoms. Hypersexuality and other aberrant sexual behaviors and drive are also reported in the dopamine dysregulation syndrome, particularly when you are using the dopamine agonist, and particularly when you are going on a very high dose of dopamine agonists such as pramipexole, lopinirole, and sometimes with other drugs like pyramidal, which are available in India. Patients with Parkinson's complain of pain, and this is again very often ignored. They undergo a lot of MRI, cervical spine, lumbar spines, as they have a pain in the back, but its pathophysiology is unclear. And we do see various pain syndromes associated with Parkinson's disease, such as early morning dystonia can be painful. Musculoskeletal pain is very commonly seen, particularly backache and knee pain. Oral burning mouth syndrome and genital pain do occur, and they may be the side effect of the dopaminergic treatment and need to be recognized. We also have non-motor symptoms because of the fluctuation in the symptoms related to the drug therapy. So wearing off phenomena where the patient's dopaminergic drugs effect has worn off. And this results in anxiety, pain, tingling sensation. Sometimes they talk of coldness in the limbs, restless leg, and unclear thinking. 17% of the patients experienced non-motor symptoms associated with the wearing off phenomena, which included sensory symptoms, breathlessness, nausea, facial flushing, hunger and pain, and occasionally sweating as well. So what are the take-home messages? Identify the core features of Parkinson's for making the diagnosis, such as bradykinesia, rigidity, or tremor. That means these are two separate. Identify the red flags, which I mentioned at the beginning of my talk, to differentiate the other Parkinsonian syndromes. It's very important because of the prognosis involved with the other Parkinsonian symptoms. Recognize on and off because it will help you adjust their medications. Freezing of the gait, postural instability has to be addressed because this will prevent the falls and hospital placements, and identify non-motor symptoms which are often neglected, are often not asked, and may be treatment resistant and cause significant amount of disability. Thank you. I end my talk here.
Thank you, Charu. You covered entire Parkinson disease clinical spectrum, and I will invite Dr. Ravi Yadav, my co-chair, to call upon the next speaker.
Thank you, Dr. Charu, and thank you, Dr. Sanjay. I am again thankful to IN and API for conducting this meeting, and I also have some association with Dr. Shyam Sundar, whom I was really fortunate that I met him during my MD exam. He was my external examiner 17 years back in KGMU. So it's really nice to see you, sir. So now I call upon Dr. Rishikesh Kumar, who will be talking on management of Parkinson's disease. And Dr. Rishikesh Kumar is the head of Department of Neurology and Director of Research and Vice Chairman at Institute of Neuroscience, Kolkata. And he's a dynamic Secretary of Movement Disorder Society of India, member of Education Committee of Movement Disorder Society, AOS section, and Chief Editor of Movement Disorders in Clinical Practice, Indian edition. And he has several noticeable achievements. His research interests are Parkinson's disease, and he's an expert in gait disorders, multiple publications in this field. And in the field of social work, he's a founder, president of Parkinson's Disease Patient Welfare Society of Kolkata and SCA 12 Consortium. Now I invite Dr. Rishikesh to deliver his talk.
Thank you, Dr. Ravi, and it's amazing initiative of IN and API. API has been our mother organization, IN has been a mother organization. So I'm very glad to be here and talk about Parkinson's disease. Okay, talk about management of Parkinson's disease. What I find as a neurologist, Parkinson's expert, the disturbing tendency to diagnose Parkinson's is casually. Any person who says that I'm a little slow, I can see that sometimes they diagnose Parkinson's disease and they start receiving levodopa. So PD is a diagnosis largely clinical. Onus is on us not to err, to diagnose clinically and accurately by using the methods what Dr. Charu told us, that bradykinesia is very important. Without that, we should not diagnose Parkinson's disease, and there's a way to see bradykinesia, which Charu told. There's no shame in holding the diagnosis and seeing the patient again in a few months' time if there is any confusion. I will add 2 points here that regarding diagnosis, and then I'll go to management. I give a lot of importance to stance base. So if stance base is narrow, Parkinson's is more likely. If stance base is wider, stance base is wider, then Parkinson's is less likely. That this patient, the first patient is Parkinson's disease, and you can see that wide stance base, arm swing more, that is less likely Parkinson's disease, and this patient is a case of vascular Parkinsonism. That can be seen in NPH also, wide stance base and increased arm swing. Second, when we talk about treatment, there's clear difference between treatment and response in tremor-dominant Parkinson's disease versus PIGD. That means postural instability gait disorder, means slowness dominant. This patient, tremor-dominant Parkinson's disease, they respond well to levodopa, but on a higher dose. On a small dose, sometimes they don't respond, and in fact, tremor may worsen because bradykinesia is taken away and tremor may worsen. These patients have clear on-off phenomenon. They're slow, they're stoop forward, clear on-off phenomenon. But difference is that I won't like to have bradykinesia and rigidity dominant, because tremor dominant, they may look bad, but progression is slow and cognition is less impaired as compared to PIGD variant. With this, when to start treatment? When you diagnose a case of Parkinson's disease, that doesn't mean that we have to jump on all the treatment. And sometimes we see the prescription having all the medication possible right from the early Parkinson's disease. Parkinson's should be treated only when the patient has symptoms that are affecting the daily activity. Symptoms will be there, but affecting the daily activity. So first consult is very important. Once you diagnose Parkinson's disease, we have to sit with the patient, discuss their job, discuss their activity profile. And unless it's really, really bothersome, we can withhold the treatment. Now there's a recurring theme that, doctor, you're treating me for 4 years and still it's worsening. It's not getting cured, because patient expectation is cure. For all the reasons, the expression cure. The fact is that right from the day one, when we see the patient, we should impress upon that we treat symptoms. There's no medicine to halt the progression, no effective neuroprotection. So whatever we use, coenzyme Q, selegiline, vitamin E, and rezagiline, either they are useless or very minimal effect. So that we have to impress from day one. And we treat symptom in wonderful way. The reason is that any degenerative condition you can think of, they don't respond to medication as compared to Parkinson's disease. So we have instruments for that. Coming to neuroprotection, only one medicine has gained some traction in the last few years' time. That is rezagiline, on the basis of Adagio study, which is a big study published in NEJM in 2009. But in that study also, when you see that the difference in long-term difference after 6 years time, 66 weeks time, was 3 point in UPDRS. And this 3 point is so small, those who are using UPDRS as a scale for Parkinson is so small that you cannot say with conviction that this delays the progression. So essentially there is nothing which is neuroprotection that can help us to slow down for a long time. Now coming to treatment options available, levodopa, dopamine agonist, amantadine, anticholinergic, COMT inhibitor, and MAO-B inhibitor. We'll come to them. But there have been some trend of treatment over the last couple of decades. When I started my career and right now in the last 20 years, a clear difference in that. And the difference is that selegiline we used to use quite a lot, this out of fashion. Cabergoline was used for a few years, about 20 years back. That's out of fashion. That came and disappeared. Cabergoline is a dopamine agonist. Tolcapone, COMT inhibitor, was withdrawn because of hepatotoxicity. Bromocriptine and pergolide was still around, but they are hardly used. They are agonists. Entacapone is being used frequently, but has lost its initial enthusiasm. Initially, we thought that this is the way for continuous stimulation, but it's lost initial sheen. Drug holiday was used to improve the sensitivity of levodopa, but that is being avoided. That can be dangerous also. Sulfonamide has come into picture. It helps in prolonging the effect of levodopa and also to help in reduction of dyskinesia. We'll look into it. There's more awareness about DBS and apomorphine pump. They're more acceptable in the physicians as well as patients. Furthermore, monotherapy in early Parkinson's disease is preferred. We should not jump on polytherapy unless really needed, and that too in later stage. Neuroprotection has largely failed. Levodopa is gaining its ground. Robust evidence in early Parkinson's disease also that levodopa can be good as monotherapy. So 20 years back, we tried to avoid levodopa as long as possible, but things are changing and things have changed. So major change, the levodopa phobia is waning off. And when you see this chart, this is a nice study published in Brain, where they saw that when Ghanaian patients in Ghana, they did not receive levodopa for long time. They started here. This dark blue is very good phase, and then started having wearing off and dyskinesia. As compared to Italian patient, they have had levodopa at this stage. The honeymoon phase or good phase was long, and then started wearing off. So what this chart tells, what this data tells, that when you withhold levodopa for a long time, that doesn't guarantee long on phase. That doesn't guarantee long honeymoon period. That doesn't guarantee late dyskinesia. So everything you can see that the honeymoon period was small, but dyskinesia wearing off came early. This again gives the clear evidence that levodopa is not a taboo. So don't delay, start today. That is one article from Anthony Lang. We'll talk about that again. Then another option was using MAO-B inhibitor with levodopa or without levodopa as initial treatment, as rezagiline was used earlier, as selegiline was used earlier. But open label study was very clear that there was no clear difference in dyskinesia and long-term dyskinesia when you delay levodopa. So treatment has largely revolved around levodopa. What are the formulation of levodopa we use? 100/10 levodopa carbidopa, 100/25 levodopa carbidopa, 225/50. These are immediate release. These are rapid release formulation. Then we have CR, control release, 100/25 and 200/50. Rest others are not available in India, so we will talk about that. But these are practical. We should discuss about it. For clinical practice, levodopa carbidopa 100/25 or 100/10. When you see 100/25, this works best as compared to 100/10 because less nausea and more effective. So generally, it's good idea to start 100/25 as an initial therapy. When the patient requires a lot of levodopa in advanced stage, say 8 tablets and 10 tablets, then beyond that level, carbidopa is not very useful. And beyond the level, carbidopa can seep into blood-brain barrier, can go to the brain, which we don't need. So on a higher dose, suppose the patient 800 to 1000 milligrams of levodopa, it's a good idea to shift to 100/10, and to start with 100/25 is practical. So when to use levodopa carbidopa CR preparation? Again, CR was in vogue. CR was supposed to be control release, that means longer acting. Patients and doctors felt that only 2 tablets or 3 tablets a day will work as compared to levodopa carbidopa regular combination. But it was found that the release of levodopa was erratic. Plasma level was erratic. So it was not very useful in giving proper clinical improvement in patients. And apart from that, the longevity of levodopa was not used. It's slightly more than levodopa carbidopa regular combination. It was not used. But still I use, and it's being used in nighttime if it's troublesome. If the patient is going in the night, rather than giving every 3-4 hours of levodopa carbidopa regular combination, we can go for levodopa carbidopa CR. So there is a role of CR. Coming to entacapone. Entacapone, as we know, that's COMT inhibitor. COMT means levodopa degeneration. Levodopa metabolism it inhibits. So with the hope that levodopa can last longer, there are a lot of studies using entacapone, this COMT inhibitor. Stride PD is mentionable. We should mention about that with the hypothesis that entacapone helps in prolonging the effect of levodopa and hence provides continuous stimulation. But when it was studied, it was found that it did not prolong that much, but it increased dyskinesia quite a lot. So dyskinesia was much more common with entacapone as compared to only levodopa carbidopa. And again, this lost its sheen. Come to MAO inhibitors, we talked the selegiline was not found to be very useful in long term. Razagirin, we saw that it can delay the progression to some extent. Data is not that robust, and safinamide is being used nowadays on the basis of some studies. And one of the study was the first author was Rupam Borgohain, and it was a wonderful study. The RCT was done, and safinamide found to be moderate to advanced Parkinson disease. It reduces motor fluctuation to some extent, and it does increase the time of levodopa function to some extent. So safinamide has been found useful. And this has been vogue in India, especially. We use 50 milligram once a day. We can build up to 150 milligram a day. And there's a data showing that the blue is 50 mg, the dark blue is 100 mg. And you can see clear difference. The total daily on phase was more in blue and dark blue. Total daily on phase without dyskinesia was more. So safinamide has some role. Now coming to Parkinson's PD initiation, we talked that levodopa is not a taboo, but still in young Parkinson's disease, dopamine agonist, and if the patient has a tremor dominant, anticholinergic can be useful. A tremor dominant, we talked about anticholinergic. There's a subset of YOPD who responds to this anticholinergic very well, and that for a long time. So this can be tried in young YOPD. If the above treatment not very effective, start levodopa. Razagirin can be started in the hope of delaying the progression, but evidence is thin, as we talked. Now coming to agonist and anticholinergic, we feel that they're holy cow, and a lot of people, they use this early for long time and delay levodopa. The fact is that they have a lot of side effects, like anticholinergic, they have dry mouth, retention of urine, confusion state, cognitive decline, and agonist, excessive somnolence, hallucinations, impulse control disorder, like compulsive gambling, hypersexuality, compulsive shopping, funding, etc. Now, the patient did not respond that well to those medication. You shifted to levodopa and the patient started to respond to some extent, but there's tendency to underdose when it comes to levodopa. Often we see that half tablet twice a day, half tablet 3 times a day, and patients, they don't respond, they don't have improvement in activity, and we feel that it's not working. When you start levodopa, commitment should be full. It's 3 to 4 tablets a day, spaced 4 to 5 hours 1 hour before food or 1 hour, 2 hours after food, that is the dose when the patient starts showing some improvement. So we should not shy. We should not keep very small dose. If the patient is not responding, we should gradually build up the dose to 3 to 4 tablets a day, and you will find response in majority of Parkinson's patient. As it is progress, we can go further high. We can go to 1500 to 2000 milligram a day. 100 plus 25 is better tolerability. We talked about that. CR preparation have limited use. We talked about that. Entacapone has limited use because of dyskinesia. There's no consensus dose, but we can go up to 1500 to 2000 milligram of levodopa. Now, time passed by. The patient was doing very well. They have on-off phenomenon, which Charu showed. This is off, this is on. But what happened that in due course of time, the on lasts for only 1 hour time, only 2 hours time. That motor fluctuation started. And in that on phase, many patients starts having dyskinesia. So this is very, very common. The patient will respond very well initially. Later on, they will have on-off phenomenon. They will have dyskinesia, and their strategy should change should be modified to some extent. This is a cartoon to show this green area is on, very good fluctuation in that on phase without dyskinesia. As the disease progresses, more dyskinesia, and you can see that things are not getting well. So to manage on-off phenomenon, we should increase the frequency of levodopa. That's the best strategy. If you're giving 3 times a day, 4 times, 5 times a day, there's no harm in that, and you'll see that off phase will reduce. You can think of addition of entacapone, razagalin, dopamine agonist, amantadine, the various papers on that, but generally they are not very effective. In case of morning off, I often tell the family members that if early morning off, if you give levodopa in the night time, it won't work till morning time. So it's good to give very early morning addition of levodopa. Suppose somebody is getting up at house at 4 a.m., 5 a.m., wake up the patient, give one levodopa, and when the patient is getting up, he will be much better. And DBS surgery is one option. Many times we keep on talking about motor fluctuation, but we should not understand non-motor off, anxiety, depression, fatigue, pain, and bladder symptom. They do respond to various medications, anti-anxiety, but they respond to levodopa also. If you're very clear that this anxiety, depression, fatigue is in off phase, they will respond to levodopa better than anything else. This patient can see the face. This is off phase. On phase, she is very cheerful lady. She keeps on talking. She keeps on walking. The off phase, she is depressed. She's in pain. And in such case, the medication of anxiety or pain didn't work well, and levodopa worked much better because the patient had anxiety in off phase. So off phase, give levodopa. Motor fluctuation, now dyskinesia started. The patient can have off dystonia. Of course, the patient can have peak dose dyskinesia, and sometimes biphasic, means when they're going on and when they're coming off. Out of that, dystonia is very common, off dystonia. In that case, spacing the levodopa more frequently, then dystonia will be less because you're reducing the off phase. In case of peak dose dyskinesia, this is very common again. In that case, that strategy should be, hold on. Before strategy, I'll tell you that if the patient has dyskinesia, mild dyskinesia, don't bother about that, because that dyskinesia affects family members more than the patient. Patients are happy with that because they need on. They don't care about mild dyskinesia. So mild dyskinesia, no need to treat. But worse dyskinesia like this, you have to treat. This is really bad dyskinesia. You have to treat. This is levodopa peak dose dyskinesia. And in that case, the strategy should be smaller levodopa dose if possible. So multiple times, but slightly smaller. Suppose you're given 2 tablets, go for 1.5 tablet. This may help. Addition of amantadine. This has got some value. Double-blinded trials are there for amantadine, clozapine. Addition of amantadine, addition of clozapine, that may help in dyskinesia. In fact, clozapine is a good medicine in the sense that it can help in some other symptoms, psychosis in that stage, as well as dyskinesia. Clozapine can cause blood issues, so we have to check blood regularly, CBC regularly, neutrophil count regularly. Zonisamide recently got some evidence, but I have used in about 15, 20 patient, they have not responded that well. And if the patient has dyskinesia, bad dyskinesia, on-off phenomenon, DBS surgery, apomorphine pump is other options. Myth of drug holiday. If the patient has a lot of off phase, I've seen that sometime in old days, they used to have drug holiday, thinking that the patient will have increased sensitivity and they will respond well. But drug holiday is complete no, because drug holiday can be dangerous. As happened in this patient who forgot the medication, she went to Puri, she forgot the medication in Calcutta, and she came back in such dire state. And this can be life-threatening, what we call as dopamine deficiency syndrome, acute dopamine deficiency syndrome. Another way is continuous dopamine stimulation, a way to avoid motor complication. Means when you keep on giving levodopa or dopamine continuously throughout the day, there's no real way for that with medicine, I can tell you. But throughout the day, the complication can be delayed. So that's the rationale. And for that, apart from rather than medication, what works is duodopa, which is not available. Duodopa is levodopa gel. DBS, and apomorphine pump. Apomorphine pump has come into India about 4 or 5 years back, and Toledo study was done. It showed clearly that from baseline, on phase was good and on without dyskinesia was good. So apomorphine has value in on-off scenario. Now coming to practical scenario, patient, we have seen COVID era quite frequently. The patient was doing well. In over a few days, he has suddenly deteriorated. Parkinson's disease doesn't deteriorate so rapidly. In that case, apart rather than Parkinson's, we should look for other things. Whether the patient has missed the dose of levodopa, with the intake of dopamine receptor antagonist he has done in the form of levosulfide or any other medication. We'll check the medication list, weed out unnecessary. As the patient advances, weed out unnecessary medication and we'll be happy. Imbalance, sodium-potassium imbalance, sepsis, UTI in sepsis. This is very commonly with patient has stable Parkinson's disease. UTI or sepsis can worsen Parkinson's symptom, and you keep on increasing levodopa. You improve UTI, you improve sepsis, and patient will improve. And SDH sometimes can complicate Parkinson's disease, and you feel that patient has more Parkinson's symptom, but in fact SDH is there, and that has worsened Parkinsonian symptom. As we discussed, don't underestimate non-motor signs of Parkinson's disease. They all deserve treatment because they can affect quality of life more than no motor symptom. That include dementia, psychosis, anxiety, akathisia, urine problems, sleep problems. So principles of treatment, young onset Parkinson's, you can think of various medication, anticholinergic, dopamine agonist, but don't be shy of levodopa. If the patient doesn't respond, the patient is losing his job, go for levodopa. Older patient, levodopa is the first choice. Simplify regime, less is always beautiful. Levodopa-induced dyskinesia, small dose multiple times, but if it doesn't work, add amantadine, clozapine. DBS for selected patients. Advanced Parkinson's disease is important to distinguish motor complication, which are levodopa responsive. So once you know that levodopa responsive, increase multiple dose of levodopa, and same with the non-motor. Avoid aggressive treatment of dyskinesia. Mild dyskinesia, leave it. Moderate to severe, then you can go for that. Do not chase non-disabling off symptom. Changing CR preparation to regular preparation, better control. CR generally doesn't have that much control, except in the night time I give, and there's some data about that. Weed off unnecessary medication. Medopar was available around, nowadays not available. Levodopa benzerazide may be helpful in on-off phenomena, especially when you have intolerance to levodopa carbidopa. And thank you very much. This is my research team, my team which keeps on helping me. And thank you very much, API. Thank you, IEN.
Thank you, Dr. Rishi, for summarizing the whole management within such a short time. I'm sure the audience will have a lot of questions, and we can address them just after these talks. And so now I call upon Dr. Sanjay to invite the next speaker.
Yes, Dr. Rishi, it was an excellent talk, and I can see there are many questions coming in the chat box, and we are going to address them. They are very practical questions. So before we take those questions, we have a couple of more talks left. So for the third talk, I will like to invite Dr. Meenakshi Sundaram, and he's going to talk on Parkinson's plus syndrome. And we all know Dr. Meenakshi Sundaram, and he's current secretary of Indian Academy of Neurology, and a motivating force as far as movement disorder is concerned. He first organized the Movement Disorder Society of India conference in Chennai, and we all look forward to his talk on approach to Parkinson's plus syndrome. And he is currently Director of Neurology, SIMS Hospital, Chennai. And welcome, Dr. Meenakshi Sundaram.
Thank you, Sanjay. Thank you to the presidents of both the societies for organizing such a wonderful meeting. And Secretary Indian Academy, it is indeed an honor to be part of this, not only as the backup team, but also as faculty. Now, we've had wonderful talks, and I'm sure you're already very enlightened about Parkinson's. So here we are. There will be some overlap, obviously, because we will talk about Parkinson plus syndromes. So when we talk about Parkinson plus syndromes, now this is something that Greenfields with the neuropathology, the 7th edition said. It is now recognized, it was then recognized, then itself recognized that there are many causes of shaking palsy Parkinsonism, with frequent clinical misclassification. Why is it important? Because I am sandwiched between the management strategies, and it's very, very important for anyone who is managing Parkinson's or Parkinsonism to know, first of all, whether they're dealing with PD or they're dealing with atypical Parkinsonian syndromes or Parkinson plus syndromes. So it's very important to do that differentiation before we start treatment, or even as we are treating and find things are not going all right, we need to revisit the diagnosis. This has been already alluded to. Dr. Charlotte has actually enlightened us about that. I'm just going to go to this. No, she said about, no, the first step is obviously diagnosis of Parkinsonism. First of all, the mistake shouldn't happen there. Then we go on to whether this is PD or this is Parkinson plus syndrome. Know that bradykinesia is the basic clinical finding on which Parkinsonism is diagnosed. So there must be slowness of movement, and there must be decrement in amplitude or speed as the movements are continued. For example, we'll see two videos here. So fine. So the first one, you saw that video, that is definitely slowness. Now that is slowness, so should we call this bradykinesia? Look at this one. You can see that the second one actually has gradually reducing amplitude, and this, as they keep repeating, is very important to make a diagnosis. The first one is actually only a spastic hand. So anything that's slow is not bradykinesia. It has to be, as they continue doing the movement, the repetitive movements, they become slower and they also become smaller in amplitude. Please remember that. And it is important to know that limb bradykinesia must be documented to establish a diagnosis of PD. Just touching upon it. So now we'll talk about, Charu said this, about if you have early postural instability. What is postural instability? And this is how we test it. Advise that you stand against a wall and pull the patient, especially if the patient happens to be a little overweight and you are not that very well built, then it's important to be careful too. But if the patient has what happened here, it goes on backwards, and that's called postural instability. Normally they're able to stabilize themselves or max take one step and stabilize, but if we go on, then it's called postural instability. Now, apart from, so those are the red flags that Dr. Charulata had actually mentioned in detail. I would say that it's very important that you make a diagnosis of orthostatic hypotension very carefully. Make sure that there are different criteria. The MDS criteria says that 3 minutes of standing. Well, we have had many other criteria, that is the Barrett's criteria and all that, which even 20 millimeters. But anything more than 30 systolic or more than 15 systolic is subnormal. But anyone who has anything more than from 11 to 29 is supposed to have borderline. And please remember that too. So, but make sure that there is no dehydration, medication, other diseases which can explain autonomic dysfunction, especially in the setting of a physician's practice. So recurrent falls within 3 years of onset. So that we test not only by falls, because of the postural instability. So these are important points to remember. And please remember that if somebody has a bilateral symmetric Parkinsonism, we need to be very, very careful in making a diagnosis of Parkinson's disease. It's a definite red flag. So what are the features that predict atypical Parkinsonism? If the disease progresses rapidly, we know that Parkinson's disease by nature, a degenerative disease which goes on slowly. A rapidly progressive Parkinsonism is very important. Early gait instability and falls, absence or paucity of tremor. You can have rigidity dominant Parkinsonism, but an absence, total absence of tremor even after 5 years into the illness would definitely be a red flag. An irregular jerky tremor, not the regular rhythmic tremor of 4 to 6 hertz, myoclonus, or if the patient has poor or absent response to levodopa. But we make sure that, as Dr. Rishi pointed out, you give adequate doses of levodopa before you declare the patient as levodopa non-responsive. The additional features, and these are the important ones, abnormal eye movements as occur in PSP or progressive supranuclear palsy, pyramidal tract cerebellar signs as occur in MSA, dysautonomia as in MSA, severe dysarthria, dysphonia, stridor. Stridor can be a very prominent manifestation sometimes, and this is multiple system atrophy again. Somebody has apraxia, an alien limb, or myoclonus, should think about corticobasal syndrome and early prominent dementia.
Now, this is a very important slide because without these syndromes cannot be diagnosed. Let's just remember that. We can talk about many subtypes, but it is very important to have these findings before you think of the Parkinson plus syndrome. So you just have to remember to examine for these findings as we examine the patient. Right. So that's a criteria application. I'll skip these. Right. We will just see that this is a patient that has presented with Parkinsonism, and we look at her eyes. Right. So that's the first thing we do. We ask them to look to either side. We are testing saccades. Anybody who's interested in eye movements would know that. So we're testing for saccades. Saccades are fast eye movements. If you ask someone to look to the left, to the right without any stimulus, it's called memory guided. This is self-generated saccades, and those are self-guided or self-generated saccades, and these are very important. And these are very important in Parkinson's. These are the ones that are affected. Now, when you ask them to look from left to the right, or you show your fingers and ask them to look between the two fingers, left and right, then actually, if you can see, a simple clinician's clue would be that normally the saccadic movements are so fast. They're very fast. I'm sure most of you would know about the speed of the saccade. There's about 700 degrees per second. You know that it's like that, and the eye can go 2 times around. 700 degrees, which means that you ask someone to look from one finger to another, you can't see the eye move. And if you can see the eye move from one target to another, then you can be sure the saccades are affected. And more importantly, it's very important to look at vertical saccades, which are affected in Parkinson's, progressive supranuclear palsy, or PSP. So in the vertical saccades, up gaze restriction can occur in the elderly to some extent, and also in PD. But down gaze or the downward saccades are the ones that are more important. Or if the patient presents to you sitting like this, this is truncal swaying to one side, then you make sure that you're not missing out on a Parkinson plus syndrome. This is an advanced stage of the disease.
इस साइड पे, उस साइड पे, इधर उधर फास्ट देखना, इधर देखे, साइड पे देखे, ऊपर देखे, नीचे देखते रहिए.
Right. Here you can see that the eyes aren't moving vertically at all. Horizontally, there's a very slow movement. This is a slightly more pronounced presentation of PSP from what we saw in that lady. So when we talk about this is how the chart would work out like. You have Parkinson's disease, then you have secondary Parkinsonisms, which are due to vascular, infectious, drug-induced, metabolic, tumor, or NPH. You can have hereditary Parkinsonism. There are many others. Now we'll leave this. This is a slightly older slide. And there are atypical Parkinsonism. These are the 4 important conditions that we must remember: PSP, CBD, MSA, and DLB, or dementia with Lewy bodies. So these are the 4 syndromes that primarily, we will concentrate primarily on PSP and MSA today. That beyond this lecture to be talking about everything in detail. So there is multi-system disease within the brain. That's why it's called PSP, CBD, MSA, DLB. But early the GOMS disease are Parkinsonism, dementia, amyotrophic lateral sclerosis. Remember that all those heredodegenerative disorders, including Wilson, come under heredodegenerative causes of Parkinsonism. And they are not Parkinson plus syndromes. So the features that are suggestive are, this is a big list. We won't go through one by one, but there are some prominent things like poor or no response to levodopa. And the patient has no dyskinesia despite high levodopa dose. Unilateral signs are seen like limb apraxia and myoclonus in corticobasal degeneration. And they sometimes have no wrist tremor at all, then you should be very careful. Can occur in all 3 syndromes. Like I said, if you have an enterocollis, if you have a laryngeal stridor, if you have contractures, these might mean MSA. But if you have eye signs, then you think of PSP, making it simple: impaired down gaze, deep facial folds, palilalia, meaning that repeating. You ask them their name, they'll say that 2-3 times. So that's palilalia, saying the same thing. Early loss of postural reflexes, all those will primarily be PSP. And sometimes when you give levodopa, this is a classic finding. That can be facial dystonia with every dose of levodopa. And that can be a clue for multisystem atrophy or MSA. So that's very important to remember. So when you look at the red flags, the motor red flags, there are many signs. We have many, but what I showed you, like that lady tilting to one side, is actually, what does it look like? It looks like the Leaning Tower of Pisa. So it's called the Pisa sign or Pisa syndrome. But many others, like early freezing, early instability and falls, poor response, a stimulus sensitive myoclonus, as I said, orofacial dystonia. So these are motor, and there can be other autonomic symptoms too. Autonomic symptoms, as we classify autonomic function tests, these are either heart rate tests or they are BP tests. And you have to then, but you can have progressive anhydrosis or fecal incontinence even in patients with Parkinson plus syndromes. Oculomotor, apart from the vertical saccades, they can have difficulty in initiating saccades. And that can be, one of the manifestations can be that to initiate the saccade, they need to blink. So if this should be an early sign to see from one place to another, patient looks to the one side, then he has to go to the other side, he blinks before the eye can move. And that's something that will tell you that this is an early form of difficulty in initiating the saccades. Square wave jerks are minor jerks that occur in the eye at rest, and these are again said to be more common in PSP. Then there are the cognitive neurobehavioral, as well. If you have an early dementia, you'll have to think about DLB or diffuse Lewy body disease. So this is another classification. According to protein aggregation, the atypical Parkinson disorders have been classified into synucleinopathies and tauopathies. Synucleinopathies are PD dementia, dementia Lewy bodies, and DMSA, while the tauopathies are PSP and corticobasal degeneration or CBD. So there is other pathies now added. So we have synucleinopathies, which includes familial Parkinsonism, TDP-43 proteinopathy, amyloidopathy, and tauopathies. The history of all these atypical Parkinson's is quite long. I'm just, that MSA, we started in 1900 itself. It's a cerebellar presentation, an autonomic presentation, which was described. Many of us knew Scheidegger syndrome only when I was doing my MD in 34 years ago. We were talking about Scheidegger syndrome, and we know that now all that has come under the umbrella of MSA. Similarly, DLB was first described in 1961. Then they had the Lewy body variant of Alzheimer's in 1990. Then the neuropathology of Lewy body disease were delineated in 1993. The first diagnostic criteria of DLB came in 1996. So this is nothing new. This is all more than at least a quarter century old, but we're getting to know them better and better about the other diseases too. We're talking about PSP and we're talking about CBD. MSA, this was a landmark paper which came in 1989 and done by Niall Quinn, who was done pioneering work on MSA. It was supposed to be, a rare disease when it started. And this is a nice thing. This cartoon, I like it a lot. So they had idiopathic, this is the cartoon that came in that article. Idiopathic orthostatic hypertension, Scheidegger, OPCA, SND, people who are who run their MDs and who have been to examinations as an MBBS MD in the 80s would remember about OPCA being a common diagnosis that was to be presented in the examination, SND and all that. So pick a name or call it MSA. And it's that simple is beautiful. That's what cartoon says. So there are many definitions. As I said, there are many definitions of orthostatic hypertension, starting from Schatz to Bannister and Matthias. So where Bannister says fall of more than 20 and standing is found, then further investigation justified. But many of us go by this 30 by 15. So this was what the article initially said about SND type and OPCA type. Now we know that this is MSAP and this is MSAC. And how beautifully the whole thing was explained even then, and why we should think of multiple system atrophy and when we should be thinking about it. So the clinical presentation, the MSAP is the onset is more than 40 years. duration said to be less than 10, but now we know that it can go on for many more years too. So I have a patient who has lived even 15 years. And MSAC, so how do you make this diagnosis? But we know that this is a degenerative disease. One subtype can evolve into another. Let's remember that predominantly Parkinson's means MSAP, predominantly cerebellar means MSAC. But a patient who is Parkinsonian today can go on to develop cerebellar or the vice versa. But then how do we diagnose? The diagnosis is made on the predominant presentation at the time of examination. And that's a point to be remembered, how we classify. I will probably skip this. These are criteria for how MSA. It's important, as I said, that you must document that there is autonomic failure, poor levodopa responsive Parkinsonism, and cerebellar syndrome. So one of them should be there, and this is how it's diagnosed. But you can, but for a definitive diagnosis, you definitely need neuropathological correlate, which is not practical for a clinician. So then we have possible MSAP or MSAC, and we have possible MSAP. These are the things. This is fairly, this is not very typical. These are these gray zone or borderline cases. I'm skipping those. So these three gentlemen, I hope you all recognize them. These three gentlemen, neurologist J. Clifford Richardson, pathologist Jerry Olszewski, and John C. Steele, who joined neurology residence in 1961. So we know what we're talking about: Richardson, Steele, Olszewski syndrome, or PSP, and that's what they define. There are quite a few ways to look at the approach. This is a little complicated way, but if you look at it, the progression, if you look at how they progress, most of these Parkinson plus syndromes progress relatively rapidly. The life expectation isn't as good. Good is not the best word, but I would use it for want of a better word. So it's not as good as Parkinson's disease. Postural instabilities occur initially, and partial instabilities can also occur in CBD. But when you look at the dementia phenotype, partial instability, postural instability is late. There can be CBD as a lateralized phenotype where they have apraxia, myoclonus on one side. So it's important to know some of the common things. Progression is rapid. Parkinsonism is most symmetric, but it can be asymmetric or distal in MSA. In PSP, it's symmetric. It is asymmetric when somebody presents with a lateralized phenotype in CBD, and it can be asymmetric in DLB too. But levodopa response can be there initially, at least in PSP, which then goes up, probably lasts for a year or two, and then it is gone. The levodopa response can also occur in 1/3 of cases of MSA, but they're usually not there in the other type of Parkinsonism. So these are some of the ways that you can see. So if somebody presents with a lateralized phenotype and has some myoclonus, for example, then you are talking about CBD. So this is how a clinical picture is analyzed, and then you make a diagnosis. So if you look at a clinician's point of view, then look at whether the patient responds to levodopa or does not respond. So if he has a beneficial response and there is executive dysfunction which is mild, then it's probably Parkinson's. A levodopa responsive, but there is significant executive dysfunction. Executive dysfunction, the ability to carry on most of the regular activities of life and executing, even something like presenting here or cooking, all those things are executive functions of the frontal lobe. So if they're severely gone, then we're talking about diffuse Lewy body disease. If the patient has a good levodopa response, has language and visual dysfunction and early visual hallucination, then you are thinking about DLB. The patient doesn't respond well, then we're probably talking about MSA, PSP, DLB, or CBD. We're not bringing in Parkinson here at all, if you see. So a lack of response with executive dysfunction, again, it can be MSA or PSP. MSA does not have significant dementia at all. The patient has language dysfunction predominantly, then it is probably CBD. But the patient has apraxias, apraxias have to cortical function, as we did read in our MD days. So if somebody has an apraxia, which is ideomotor classically, and which is a common one, and then we're talking about CBD. So this is the other way that a clinician can approach a atypical Parkinsonism. So just to tell you that the accuracy of clinical diagnosis isn't great. There are newer criteria even for PSP. For want of time, we will probably not go into detail, but just to tell that there are different levels and different layers in which it can be diagnosed. So when we talk about, definite it has to be a neuropathological diagnosis, and we need to know that this is probably not possible for a clinician. Then we have probably PS probable, possible, and suggestive of PSP. So this is what something I would probably make a diagnosis. And someone who looks like PD starts having a little slowness of eye movements. This is what I would write down, suggestive of PSP to be followed up, and that's what we should remember. I'm skipping a couple of slides, but there are different phenotypes in PSP. There have been at least 8 subtypes based on presentation, clinical presentation, that have been defined. The 2 most common subtypes are, one is the Richardson syndrome, which is a classic one, postural instability and the eye movement impairment with Parkinsonism is Richardson's. PSP Parkinsonism, which looks like PD, for all practical purpose and responds to levodopa initially, and that's called PSPP, and we need to remember that all the time. And this is another subtype of PSP. This patient that this is a tauopathy. So because of PSP, it can present and gait freeze. That's what she has. So this is a subtype. So she has the classic eye movement impairment. So she started off with gait freezing, but later on went on to have the eye signs as we followed her up. So this is the types I said. So you can have PSP Richardson syndrome, Parkinsonism, pure akinesia and gait freezing, the cortico-basal syndrome, which looks so much like CBD, with the limb being affected more and being asymmetric, and they have some apraxia. So that's where then they have limb dystonias too. Then there's progressive non-fluent aphasia, and somebody can present with a behavioral variant of frontotemporal dementia or a cerebellar variant. So these are various subtypes of PSP that have been defined. So quickly about corticobasal syndrome phenotypes. CBS, the classic phenotype is asymmetric limb rigidity, akinesia, dystonia, or myoclonus, plus orobuccal or limb apraxia, cortical sensory deficit, or the very celebrated but rarely seen alien limb phenomenon. Probable CBS, 2 features in each of the categories above. But then they can also have, this is corticobasal syndrome. This is what you need to remember, that this is a syndrome we're talking about, what a phenotype we're talking about. And the most common cause of a corticobasal syndrome, just to confuse things a little, is PSP. So we're talking here about a clinical presentation. We're not talking about a diagnosis. A CBS is different from a CBD, and please understand the differentiation. So these are criteria for DLB. Again, I'll just point out to the most important one. The most important one for diagnosis of DLB, what is essential is dementia. There should be a progressive cognitive decline of sufficient magnitude to interfere with normal social or occupational functions, or if you do testing, classify with the DSM-5, and if you can make a diagnosis of dementia based on DSM-5, then it is fine. 4 clinical features are fluctuating cognition, pronounced variation, attention and alertness, recurrent visual hallucinations occur early in the disease itself, not related to drugs. Many of the dopaminergic drugs can cause hallucinations. They do have RBD or REM sleep behavioral disorder, which may precede the cognitive decline. 1 or more spontaneous cardinal features, and these are bradykinesia. Without bradykinesia, no Parkinsonism. What is very striking, if you've seen in DLB, is there severe sensitivity to antipsychotic agents. They respond to even very small doses, and there are other indicative and supportive biomarkers. Lastly, is gait useful in DD in the differential diagnosis? Yes, it can. There are different types of behavior, but a PD has a narrow shuffling gait. We all know the gait. In DLB, there is less lateralization. They have a narrow gait again. But if you have a wide-based gait, then you're probably dealing with MSA-C. If the axial rigidity, early falls, you're talking about PSP. Early freezing of gait, look at PAGF subtype of PSP. Freezing of gait and falls, usually not at disease onset. Then you probably CBD. So if you have wide base, ataxic gait, small steps, start hesitation, arm swing preserved, then there is probably vascular Parkinson. We're not going into that part yet now. So can gait help in analyzing a patient with PD? Definitely yes. So just quickly, lastly, that's going to be my. This was a 32-year-old male who presented with unsteadiness, speech, and dizziness on getting up on a supine posture, talking about orthostatic hypotension of 3 years. 32-year-old male, mind you. So young man. So, but what is important in him as we go on? He also had seizures in the past, and he has history of diarrhea intermittently over the years. And these are important ones. This is what history would be very important about. So on analyzing him, he had a cerebellar presentation, and he had autonomic dysfunction too. So this would classify as somebody, see the cerebellar atrophy that's happening. So you would be, the clinical phenotype would be MSA-C. It's actually MSA phenotype, MSA-C. But when it occurs in the very young like this, very important to look at. So this is the other part of the MRI. You look at the cerebellum, you have the flu, and then you clinically is where the diagnosis before the MRI, there are xanthomas. Cerebrospinous xanthoma is one of our patients, is something that can be eminently treated, even though we have challenges, the availability of drugs in our country, but diagnosis can be done. So just to say that there can be many, many more phenotypes of many other genetic disorders, which can have MSA-like phenotype, and you can also get PSP-like phenotype. Thank you very much for the kind attention. I'll be happy to answer questions.
Thanks, Dr. Meenakshi. You covered this very difficult topic in a very nice way. And I will request Dr. Ravi to call upon the next speaker for the last talk of the session.
Thank you, Dr. Meenakshi Sundaram, for an excellent talk, and Dr. Sanjay Pandey. Now we proceed to the last talk, which is on recent advances in management of Parkinson's disease by Dr. Pramod Pal. And Dr. Pramod Pal is a professor of neurology and movement disorder specialist at NIMHANS. He's a program director of movement disorder fellowship program at NIMHANS. And he has completed his training in movement disorders from Vancouver and human motor physiology from Toronto. He has more than 340 publications in the field of movement disorders. He has been, he's the president of Parkinson's Disease Society of Karnataka, editor-in-chief of Annals of Movement Disorders, and chair of infection-related movement disorder study group, vice chair of Education Committee of International Parkinson's and Movement Disorder Society, past president and treasurer of Indian Academy of Neurology, founding secretary of Movement Disorder Society of India, and past secretary of MDS AOS. So I would now request Dr. Pal to deliver his talk.
Thank you, Ravi, and thank you, Dr. Nirmal Surya and Dr. Shyam Sundar, for giving me this opportunity. I'll just share the screen first. Yeah. Can you see my screen?
Yes, sir.
Yes, sir.
Okay, just 1 second. Yeah. So I'll be talking today for the next 25 or 30 minutes about the recent advances in the management of Parkinson's disease. My previous speakers has made it easy, actually, especially Rishikesh, about dealing with the treatment of Parkinson's disease. And you all know that it is more than 200 years Parkinson's disease has been described, and almost more than 60 years, the gold standard for treatment of Parkinson's, that is levodopa, has been introduced. And still, whatever the advances, that is the gold standard, or whatever the standard, that is the best treatment available for Parkinson's disease as of date. Now, when we speak on this topic, it is always, we need to decide what is new. Is it new drugs, new applications of old drugs, new targets for surgery, or are we talking about neuroprotection, prevention, or better understanding and thereby using some of the old drugs which was never used for treatment of Parkinson's disease. So the late David Marsden said he saw two miracles in Parkinson's disease in his career. One was the introduction of levodopa, and other was the development of deep brain stimulation for Parkinson's disease. And even after this lecture, you will realize this is the same as of now. So you all know that PD progresses over stages, the prodromal period, preclinical period. There's a lot of studies going on whether we can tackle this area, which can be not even 4 to 6 years, it could be 20 years. Even the RBD, etc., develop hyposmia when before the development of motor symptoms of Parkinson's disease, whether there are advances in therapy which can target especially the vulnerable populations, especially those who are monogenic, genetically defined Parkinson's disease in the family, whether we can target, and this will not be the area of talk for today. But PD classically progress to unilateral, bilateral stages, complications as highlighted in the previous speakers. Then ultimately they develop behavioral problems, dementia, psychosis. At each stage, there is an option or there is a there is a lot of research can be done to develop a newer therapy. So primarily we try to tackle the symptomatic treatment for motor symptoms and non-motor symptoms. Non-motor symptoms, mainly, the psychosis and other neurobehavioral problems, impulse control disorders, etc. So there are different treatments are available nowadays. And I would like to also to mention that since there's a better understanding, advances in treatment of Parkinson's disease also, it opens up the door of what not to use for treating Parkinson's disease, which can avert development of non-motor symptoms, at least progression of non-motor symptoms. I'll give you an example. We have studied and found that more than 40 to 60% of the patients in Parkinson's in India take triaxiphenyl. If you stop this triaxiphenyl practice, you can avert in probably 80 to 90% of the patients of developmental psychosis. Then there is an hypersexuality is so common in young onset Parkinson's disease. But do you know why? Most often you will see that these patients are treated with pramipexole or any other dopamine agonist, and that is one of the major causes of causing hypersexuality. So these are also recent understanding, this accounts for recent treatment or development, advanced treatment of Parkinson's disease. So our current wish, as listed by Robert Hauser, is that there should be some treatment for Parkinson's disease which will be robust and sustained anti-Parkinsonian benefit throughout the day, ameliorate or prevent dyskinesia, and slow or prevent the progression of the disease. Now, you all know that we take oral medications for Parkinson's disease, but there is a lot of problem in absorption because of the SIBO, that is intestinal overgrowth, and poor levodopa absorption, delayed gastric emptying, dysphagia, etc. So that now it is for the last many years, people have tried to see what are the non-oral therapies for Parkinson's disease in the subcutaneous route, transdermal, intragenural infusion, buccal, inhale, and the greens are already in the market. This is an old slide, but green are already in the market. These red ones have been already, it is not being used anymore, and these are already in the pipeline. More investigations are done to see the utility of this, and we will discuss few of these. So apomorphine, already highlighted by Dr. Rishikesh, I am not going to go into this. It is new for India. It is one of the oldest drugs which was described, and it is a rescue drug, and it's already now it is available in India in subcutaneous form, pump form, sublingual form, but it is still costly, and it could be a best alternative to have a rescue treatment for patients who are severely bradykinetic, rigid, and cannot undergo deep brain stimulation. So, but now it is buccal and sublingual are available, and we are just trying it out and see whether these are helpful or not. So this is the already Dr. Rishikesh told about the Toledo study. It definitely proves that apomorphine is no doubt helpful in improving the the off state. So there are other things, newer formulations of levodopa other than oral and intestinal, and it is there for a long time, and it is very, very costly, and it is not, we cannot treat patients with such a costly drugs in India. So inhale form is one of the ones which has been nowadays tried, and so you can see here that I'll come back to the inhale form, but levodopa patch pump and levodopa belt pump, etc., subcutaneous, transdermal, intergenural infusion, all these are being tried with some success, but not yet openly in the market. But inhale form of levodopa Two trials are there, and it definitely, these two graphs will show you that the inhaled form in the 25 milligram and 50 milligram compared to the oral has definitely increased the median plasma levodopa concentration, as well as decreased the UPDRS in the patients of Parkinson's disease. And it is just like treating, asthma. You may have a inhaler, and this may be a rescue treatment, or at least a treatment 2 to 3 times a day. Patients can carry a inhaler. So there are certain forms of new developments in symptomatic therapy of Parkinson's disease for motor symptoms, like different formulations of meledopa as with carbidopa or opicapone. This is already in the market. Safinamide already in the market, and this is not yet been. I don't think it has been marketed. So let us come to the safinamide. I'm not going into details because it is no more a new treatment. It is already there in the market. We were part of this study way back in 2010, and it is a good drug. It has different type of actions. A oral selective reversible monoamine oxidase B inhibitor, along with it is probably has a anti-NMDA receptor antagonist action also. And this we can give to the patients as a not as a monotherapy, as an add-on therapy, starting with 50 milligram and later 100 milligram a day. And then opicapone is a long-acting COMT inhibitor, and 50 milligram once daily with levodopa. We do not have to give like in entacapone, like we're giving about 4 or 5 times a day. This can be given just only once a day, and it is a better, long-acting peripherally selective once daily third generation COMT inhibitor. There are certain drugs for motor as well as non-motor symptoms which act by non-dopaminergic mechanism, and these are again being tried, like amantadine extended release capsules or tablets. Then droxidopa, this is there for a long time. It is not being used too often, but still it is in the one of the important drugs. Istradifylline used extensively in Japan, and then pimavanserin, which is used for the non-motor symptoms. So this is one of the studies using amantadine extended release capsules, and it has been found that there is a very good pharmacokinetic and pharmacodynamic results with this drug, and it gives a smoother level of control. But the side effects are probably less than the oral amantadine. Then the droxidopa, which is a prodrug that is converted to norepinephrine, and these were there in the phase 3 clinical trials, and probably it reduces those patients with orthostatic hypotension. These drugs may be helpful. Then we all know, as well as Dr. Rishi has told, that we have a real problem of treating psychosis. These are non-motor symptoms in Parkinson's disease. We have to avoid the triggers, but nevertheless, drugs are important, and we routinely use quetiapine because pimavanserin is very costly and not available, though it is a 5-HT receptor inverse agonist, and it has a very good, it is recently being approved by FDA, and 34 milligram once a day, but it is not yet available in the market in India. That is very costly also, and it can be used as a therapy for psychosis in Parkinson's disease. Otherwise, we use quetiapine and clozapine for treating patients. So there are then certain drugs which are again in the investigation mode, is treating the non-motor symptoms with non-dopaminergic drugs like donepezil, then duloxetine, and naloxone. These I'm not going to go into details. These drugs are easily available, but this is a different way of treating Parkinson's disease because of our greater understanding. So again, use of caffeine as well as inosine, nicotine, etc., can be used in certain cases of Parkinson's disease to treat non-motor symptoms. Now, let us come to the, so I'll again come back to the oral therapies or whatever the medical treatment, but let us switch gear to the ST and DBS, which did it really achieve all the things we wanted for treating Parkinson's disease? Probably no. There are a lot of side effects, and it is one of all, it is very costly, and then there are a lot of side effects of stimulation related side effects, and so there is always a there are a lot of research is going on whether we can change the stimulation related side effects and have newer type of leads. So thus novel stimulation techniques, brain targets, and technologies have been investigated in an attempt to expand the utility of DBS and treat symptoms that are less responsive following a standard DBS implantation. Those who routinely do DBS and do programming, you will realize it is so difficult to program because of the several non-motor symptoms and the stimulation-related motor symptoms. So there are individualized stimulation delivery with novel brain targets, adaptable DBS, and novel lead design. So these are in the pipeline. These are still available, but not in India. Novel brain targets, again, PPN is not a new thing, but they're trying for patients who has a lot of gait dysfunction. Then other targets are like zona insata, centrovidian thalamus, substantia nigra, etc. Then novel lead design. This is I'll just show you this cartoon, which you will see here. Conventional quadripolar lead electrode. You will see you are stimulating here one of these electrodes here, and there are lot of side effects because the stimulation goes in different directions in a 360-degree circle. But there can be nowadays, there are directional multipolar electrodes are available, or 8-lead electrode individual set for different stimulation levels. In different 2 stimulation levels on each side, you can have small field of stimulation. So these are our novel lead design for STN DBS or GPI DBS. Then there is another thing, concept called adaptive DBS. So to overcome the limitations and improve the DBS delivery, the establishment of a closed loop system allow therapy adjusted in real-time recording to quantify and the objective brain and behavioral changes. So it happens like this, that you have the leads in the brain. Now the leads sense that when is the dopamine going to go down, and then it activates the DBS. So this is being tried, and the various responses which can be evaluated are movement kinematics, the neurotransmitter fluctuations in a target nucleus, or measurement of local neuronal activity. So these are still in the pipeline, but this is one of the real encouraging area in those who are doing neuromodulation in patients of Parkinson's disease. Now, there are also research going on in image-guided DBS. Now, so it is a real-time image-guided DBS as well as advanced imaging techniques. So you can, so I'll just give you an example that we know that Parkinson's is also a network disease. So there are a lot of networks in the brain, and what it is people are trying to do is that whether we can target these networks rather than the nuclei in the brain by DBS, advanced imaging techniques. Now, there are certain other surgical treatments which are available, and one is the focused ultrasound thalamotomy for medically refractory tremor-dominant Parkinson's disease. So HIFUX it is, okay. And this is not cheap, and it is not easily available in India, but it is a non-invasive relative to the DBS, and you can directly make a lesion in the thalamus without opening the brain. So this is very, now it is being for tremor as well as for Parkinson's disease, it has been approved in FDA approved. And still in India, it is not being, I don't think any centers are doing this in a large scale, and probably it will soon come to India. Now, there is another aspect of HIFUX is opening the blood-brain barrier for treatment of Parkinson's disease. So this is a novel idea, but if you give, using the much lower sonification energy, with microbubbles can temporarily open up the blood-brain barrier at specific brain target to facilitate the MR-guided delivery of new therapeutic agents. So this is again in the investigative stage. Now, Dr. Rishikesh has reported this. The non-invasive vagus nerve stimulation improves gait and reduces freezing of gait in Parkinson's disease. This is way back, few years back, it was reported in movement disorders. And this is a very exciting area, and I'm sure he is doing a lot of studies in this. And so that we hope that freezing of gait, which is only we treat by giving cues, etc., this novel technique of non-invasive vagus nerve stimulation, whether it can help these patients. Now, there are also some research going on in electrical stimulation of dorsal columns in spinal cord for Parkinson's disease. Now, let us come to the last part of my talk. Certain biomaterials are being used, or certain vaccines, etc., are being used to treat Parkinson's disease, especially in the animal model. So this is one of the concept is that it is tailor-made purified human platelet lysate concentrations in neutrophins for treatment of Parkinson's disease. This has been proved beneficial in patients of in animal models of Parkinson's disease. Now, These are some of the treatments, concepts of treatment for Parkinson's disease, which are in the pipeline. One is the immunotherapy, active immunization and passive immunization. I'll come to that later on. So what happens in our brain is that during the process of neurodegeneration, there are stressors, triggers for the production of alpha-synuclein, especially in those who are having Parkinson's disease and those who are genetically predisposed to develop production of alpha-synuclein. Sorry. So the alpha-synuclein forms fibrous aggregates and plaques, and that is seen in the Lewy bodies. So then after that it enters the cell, and there is an enzyme called CABL, that is tyrosine kinase. It acts as a sensor for abnormality such as internalized alpha-synuclein plaques or aggregates, and it starts stimulating a cascade of responses inside the brain, which causes further neurodegeneration. And this happens, so the sensing alpha-nuclein plaques is activating the CABL, that is the tyrosine kinase, and converting it into a more highly aggregated form, and it is more toxic to the brain. So the concept now is to inhibit the tyrosine kinase and reduce the cell death. So one of the anti-leukemia therapy was one of the drugs called nilotinib. This was found to be effective as a CABL kinase inhibitor, and this was obviously a target to use this novel treatment. And there was some evidence in mouse model using another CABL inhibitor, radotinib hydrochloride, and a lot of studies led to phase 2 studies in human beings in Parkinson's disease, but unfortunately, this did not provide the expected results, and it was so-called a failure. But is it really a failure? Because you see this review in movement disorders, now they're finding that probably the CABL inhibitors were not that appropriate to, although the CABL inhibitor failed to demonstrate clinical benefit in 2 double-blind trials, novel CABL inhibitors are being developed, and so that they can increase the concentration in the brain. And this is definitely a promising way of treating the neurodegeneration in patients of Parkinson's disease. And there are also antibodies. There is a passive immunization of antibodies against the alpha-synuclein, and this is one of the studies which has found that this is the generic name, that serum concentrations were proportional to the dose of the dose range studied, and the drug had a favorable safety, tolerability, and pharmacokinetic profile with mild and adverse events unrelated to the drug. So this is also promising treatment. Now, there is another concept that a gut bacterial tyrosine decarboxylase, which restricts the level of levodopa in the treatment of Parkinson's disease, can be targeted. Yeah. So you can see here the bacteria in the gut actually the proximal small intestine bacteria convert the levodopa to dopamine, and tyrosine abundance fails to prevent the levodopa decarboxylation. So this carbidopa failed to inhibit the bacterial decarboxylation. So what they're trying to do is that co-administration of an effective TDC inhibitor targeting both human and bacterial decarboxylases in the gut. And this may open up novel therapeutic strategies, targeted gene or enzyme blocking approaches. Now, the last part of my talk, just few slides on the concept of probiotics. Now, what are probiotics? Probiotics are defined as live microorganisms that, when administered in adequate amounts, confer health benefits to the host. In the context of Parkinson's disease and in the context of probiotics, it is more often the lactobacillus and other, other curd-related or the oral food which is available. So what is happening is that finding some preclinical studies as well as finding some clinical studies have suggested that the probiotics can reduce the peripheral and central inflammation. And nowadays, there is a concept that probably Parkinson's disease and definitely PSP has there is an inflammatory state, a pro-inflammatory state, and these probiotics reduce the interleukin-6, TNF alpha, and also it increases the glucose metabolism, reduces the peripheral inflammation, etc. So there are a lot of probiotics has been tried in patients of Parkinson's disease. There were 2 randomized placebo-controlled trials that provided class 1 evidence for probiotics as a treatment for constipation in PD. However, the effects of probiotics on other aspects of PD was not so forthcoming. Then there's another review in Frontiers of Neurology. Here, it is a Prisma review, and it showed that the probiotics can improve cognition and gastrointestinal symptoms in patients with Alzheimer's disease, mild cognitive impairment, and those with Parkinson's disease, which is possibly through reducing the inflammatory response and improving the lipid metabolism. Recently there was in Brain Behavior and Immunity, there was a editorial that probiotics and Parkinson's, there's a long way to go, but there was, I think, one of the articles published by Ray's group, they found that the probiotics help to reduce the sudden cardiac deaths in patients of Parkinson's disease. So these are the other things which are in the pipeline for treatment of Parkinson's disease, like tackling mitochondrial dysfunction, tackling the neuroinflammation, like using the old drugs like azathioprine, and also this inosine defiperon, because there is some mineralization in the brain. So iron chelation in Parkinson's disease also is being tried. And stem cell, nothing in the to cheer about, but there are definitely research is going on to see if the pluripotent stem cells can be used in treatment of Parkinson's disease. So I just want to conclude that still levodopa, judicial use of levodopa carbidopa and dopamine agonists, what we already have, can treat patients of Parkinson's disease quite adequately. We need to know, as Dr. Rishikesh has already told, that we need to judicially administer drugs. It is not that a patient needs all the types of medications which is used for Parkinson's disease, one tablet a day like that. So judicious use of treatment for Parkinson's disease is already available, and probably apomorphine as well as deep brain stimulation or lesional therapy will definitely help in managing our patients in India. Thank you very much.
Thank you, sir, for excellent talk and covering all the aspects of the recent advances in PD. Now I hand over Dr. Sanjay. Should I hand over to Dr. Achal for the remaining part of?
Dr. Achal is going to take all the questions and invite the comments from the speakers and other panel members. Dr. Achal.
Dr. Achal, sir.
Thank you, Dr. Ravi and Dr. Sanjay. Almost we have come to the end of the program, today's program. Now we need to tackle the questions. Although most of the questions have been answered by our esteemed speakers, but I will modify a little bit of them and ask again. There was a question, how long it takes for levodopa to show the response, which have been aptly answered by Charu and Dr. Rishi. What I would like you people to tell, it is how long and how much levodopa when you consider that it is not effective. So I will request Dr. Rishi to answer.
Yes, if you have clear idiopathic Parkinson disease, one criteria is that there should be response to levodopa. So we expect response in majority of cases for sure. But there comes a stage when we feel that whether the patient is responding or not. And when you use, say, half tablet twice a day for a few months and you see that it's not working, that's wrong. So at least 6 to 800 milligram of levodopa, unless you reach there, don't say that the patient is not levodopa responsive. So that's one. And second question is that how long it takes. First of all, how long it takes to respond. If the patient is clear idiopathic Parkinson's disease, from the first dose, the patient starts showing response, but there is a dose building effect also. So to the ideal answer will be 4 to 6 weeks by the time you have reached the optimum dose of 400 to 600 milligram. And after that, how long it works in Parkinson's disease? Even most advanced Parkinson's disease, if it's true Parkinson's disease, it will respond to some extent. It never goes completely off. So for lifelong, you can say.
Thank you. Thank you, Dr. Rishi.
Can you imagine in advanced Parkinson's disease thinking that the patient not responding and stop it? You cannot imagine.
Yes. Okay. So we come to the next question, which was, this was the question by Dr. Mrityunjay Sarkar. Next question was by Dr. Srikant Swami. Do you think there are differences among neurologists about when to start anti-Parkinson disease, anti-Parkinson therapy? As you mentioned, treatment should be initiated when ADLs are hampered. So this has been quite aptly answered by Rishikesh. I believe that everyone has read that, and I will ask Rishi again to respond to that in brief.
I will respond, but I'll also ask, like others to talk about it. When we talk of activity of daily living, sir, this is very subjective phenomenon, right? So first of all, we see, I wrote there, a lawyer having mild tremor or moderate tremor, he won't like to look shaky. So despite having mild moderate tremor, you are treating. A retired person sitting at home, mild moderate tremor doesn't matter. So it's completely individual dependent, completely dependent upon what you do. So that's one. I see, have got difficulty in taking the patient's version verbatim, because many times I can see the patient is young professional, he's affected, but he tells that I can do everything and I won't like to take medication. There's some bias against medication, and they may not tell exactly what is happening. So as a doctor, as a friend of him, you have to judge that when to start levodopa, and sometimes it takes 1 year time to understand them that levodopa is needed, and they start. I also take a lot of help from family members. So I would say, to answer this question, this is individualized. Be in the patient's shoes and see whether he is being affected, and then if yes, you start it.
So you do not want to start as early as possible. You will go by the patient's choice and other things as well.
Of course,
Right.
As soon as start, I don't start.
Yeah. Dr. Meenakshi, your answer to that?
Yeah, I generally, the levodopa requirement and the dosage, when the patient comes into the clinic, in the real world setting, so it's a routine thing. I ask, hey, how are you? Is what I ask. Then the patient says, I'm good. And then he says, sir, you tell me how I am. So I always say this. I'd always tell patients that it is important for you only to tell. It's not I may be biased because I'm giving you drugs, or I may want to start you on drugs. But it is important to tell us how it impedes your daily activity, whatever your requirements are. That is what will guide treatment. And this always has to be an informed decision between the patient and the doctor. And it is very, very important. But sometimes in the elderly, I tell them about the risk of falls. I tell them that, you may not be incapacitated, but if you have this difficulty in balancing, you may fall down in the restroom. And that can be a real problem. So now you're developing a little going there, you're becoming slow, your reflexes are not that good. So I would suggest that you need it. Yes, there are some patients who don't want, but many of them do understand. But in some elderly, I do tell them that, let us not try to make you normal. This is something that I would tell the patient when I start treatment itself. That I will not make an attempt to make you normal. Both of us will aim to keep you functionally active. And that's a word that I would say in Tamil, in the local language, and in English where the patient understands. But some of them in the elderly who have cardiac disease, for example, a little slowness is actually good for somebody who has an ischemic heart disease, as long as it doesn't impair his activity. So I tell them, it's okay to be a little slow. You will not walk fast. You will not precipitate an angina. So there are practical things that I would use when I'm managing the patient.
Thank you. That is taking advantage of one of the clinical features of Parkinson's disease, that is slowness. Thank you. So we go to the next question. That is by Dr. Nirmal Pandey. Levosulfide induced extrapyramidal features leading to Parkinson's disease is not Parkinson's disease, I will say Parkinsonian symptoms. That is well known, and now people are increasingly recognizing it. And Dr. Charu has already answered. It's a symmetrical answer usually, and it must be a differential when you are looking into the diagnosis of Parkinson's disease. Thank you, Dr. Nimal, for asking the question. It's very much clear.
But I must tell you this. I would like to add this here.
Yes.
It's not just levosulfide, all the prides.
Yes.
Pride. So I always say there should be no pride while managing Parkinson's.
Yes.
Yeah, nobody should take pride, neither the doctor nor the patient.
Thank you. So the next question is, what about using safinamide for advanced PD? Dr. Rishi.
Safinamide for advanced PD. Safinamide has been touted, or when you see the evidence, this for motor fluctuation, to improve the motor fluctuation and to some extent reduce dyskinesia. And when you talk about advanced PD, that means motor fluctuation has set in. So to answer this question, yes, this is a good option, but it's not a magic drug. It doesn't work in all the patients. In my experience, 20-30% patients, they showed some response, and rest, they're okay, but not great response. So yes, it is one option, but it's not the magic option. And if it doesn't work, then we have to go for other options like DBS, apomorphine. So, but this is one option. it's well tolerable. That's a good, well tolerable. And second thing, we have clear evidence. We have evidence of double blinded trial, and our country was forefront of this trial.
Next question, Dr. Paul sir. Sankvi Gautam is asking, is there any role of levodopa in patients presenting with prodromal symptoms without motor symptoms? So you were talking about medications in prodromal symptoms.
As of now, there is no rule. I don't think we'll advise anyone to take dopaminergic drugs in patients who has, see, prodromal means what is the thing I do not know, because you are thinking of the non-motor symptoms, it is very difficult to say really they will develop motor symptoms or not. Okay, even if it is they have a risk of, unless you genetically, find that he is carrying a pathogenic mutation, still if there are no symptoms, we are not going to give levodopa, because there is always a theory that there's some toxicity of levodopa in the brain, so after the breakdown. So no one is going to advise dopaminergic drugs unless the patient has motor symptoms or RLS in the other context that can help. Yeah.
Thank you, Dr. Paul sir. Next question is by Dr. Srikanta Swami. Do you think apomorphine has a real good role in management of PD with all the side effects profile and also high cost in India? Is that the reason why, except in UK, other countries are reluctant to use? Again, Dr. Charu.
Sorry, the apomorphine?
Apomorphine. Why people are less frequently using, he wants to say, in other countries than UK?
Yes.
High cost and side effects.
There is a phobia of the injectable preparations when the oral are available. So a normal Indian mind doesn't want to use the insulin. So it's similar to what we see in diabetes. They're very reluctant to go on insulin. So it's the same way they're very reluctant to go on apomorphine. Second thing, the Indian apomorphine, which is available, there's somebody who asked the question, is it available? It's by Rusan Pharma. It's not very expensive and it is pocket friendly. Only thing, it has to be loaded in the insulin syringe and injected. They don't have the jet pen. Whereas we have another pharmaceutical which has come up is Ever Pharmaceuticals. They have a jet pen form of apomorphine and there's a pump form of apomorphine. Now, apomorphine is an old drug. So it's an old drug packed into the new packaging and launched here as a miracle drug. But I think it has its own limitations. They have the side effects similar to the other dopamine agonists. But if you ask me, it's the best dopamine agonist. It is almost similar to levodopa. So a single appropriate dose of apomorphine will show the similar response in the patient's Parkinsonian symptoms as you see in appropriate dose of levodopa. And you can titrate apomorphine better than levodopa. So in certain selected population, I think who do not have the phobia of the injections or the pumps, I think apomorphine will be a good replacement for levodopa, particularly with fluctuation.
Thank you, Dr. Charu.
Not long lasting, but not long lasting.
Yes, we do understand. Thank you. Next question is to Dr. Sanjay. Sanjay, Shaikh Sharif wants to ask, maximum dose of Syndopa used in your experience and how frequent in patients who are bedridden and rigid?
No, so if you see the UK brain criteria, it says that Dr. Rishi was answering that question, that 1000 milligram levodopa for 3 months is the cutoff for levodopa responsiveness. But in my experience, if you ask, then rarely we go beyond 1000 milligram. It's very rare, because if you give a conventional preparation like 125 milligram, 5 tablets or 6 tablets at the most are enough. And if you add with the control release or the CR release, if you add, it makes 1000 milligrams. So the maximum dose is maybe I viewed it around 1200 milligram. But the usual one is 600 to 800 milligram. This is the usual dose. And there are some patients, as they start developing dyskinesia, you have to decrease the number of tablets, because if you give too many tablets, they have a lot of peak dose dyskinesia. So you have to decrease the number of doses, and you may give small tablets, like you can give half tablet or quarter tablet at a more frequent interval. So the number of levodopa tablets goes down, but the frequency goes up. So this is the way we manage our patients.
Thank you. Thank you, Dr. Sanjay. Dr. Ravi, next question to you. Amantadine, as you know, is a very good drug if utilized properly. And I personally believe that it is less frequently used. What is your view about when to add amantadine extended release preparation?
Yeah, so this has been recently launched in India. So the usual indication will be to, like, for example, using it in patients who are on multiple doses, TDS or thrice daily. But still, the personal experience of mine is very less in this regard. Maybe other panelists, because it has been recently launched. So the group of patients, I have not actually clear experience. Any other faculty who are there who have used it and have some
Dr.
experience?
Meenakshi wants to answer.
Amantadine should ideally be used not more than twice a day. There's a long half-life, about 28 hours or something. So it's not a drug that's given thrice a day. But what the recent extended release has come up with is giving it in the morning. I think in a way it's good. I have changed some patients to that very early to assess the response. But I haven't had complaints so far. But what it helps with this, and whenever we use amantadine, we all know that it can cause hallucinations and stuff, especially nocturnal. So I always try to not give amantadine beyond 6 p.m. I try to give it before that. But so in that sense, giving an extended release upfront in the morning will probably be more beneficial, but I would wait for some more time.
Yes, sir. Correct.
139 milligram, 193 also.
193.
Thank you, Dr. Ravi, and thank you, Dr. Meenakshi. Next question is very well targeted to Dr. Paul sir. Shaikh Sharif wants to ask, how frequent will you suggest probiotic to PD if to be used? He has specifically asked to Dr. Paul sir.
See, we do not have experience in probiotics. It is over-the-counter drug. Okay, it is not a drug. It is a food supplementation, and a lot of studies are going on. It helps. It doesn't harm. So there is no harm in taking unless you sell all your property and buy probiotics. That I'm not advising. But if it is in the normal process of taking lactobacillus, curd, etc., changing the dietary modification, you're welcome. But there is definitely some evidence that constipation and certain other areas, anti-inflammations and all these things help. So I would advise that you can take, if your pocket permits, you can take. No need to take it as a only treatment for Parkinson's disease. Neither, probably, as our current knowledge goes, neither it is going to prevent the motor symptoms from developing in the near future, or neither it is going to reduce your tremor, bradykinesia, or any other symptoms.
Thank you, Paul sir. We have finished the questions, and now I think we have already crossed the time. It's 7:09. I will hand over the stage to Dr. Maheshwari and Dr. Gagandeep sir.
Sir, one question, sir. Last one. I just wanted to ask. Paul sir, can because so many of stem cell clinics are all in India, and people are getting it done with lakhs of rupees, and considering that. So, sir, do you suggest what is the status of?
We should say that as of now, there is no therapeutic role of stem cells for Parkinson's disease, and this should be very clear to the Indian population. And government, API, IN, everyone should take it up to prevent this from occurring, and which is occurring, like over-the-counter type of thing. Anyone can just get a stem cell and then come for DBS again. They're coming. So I think this forum should strongly condemn the use of stem cells in therapeutic role of Parkinson's disease in India.
Okay, thank you, sir. Now it's time.
Guideline is very clear. Stem cells are not useful in any of these neurodegenerative diseases except in research setting.
Yeah, therapeutic. Yeah, that's
so very clear. I think we should.
But it is happening. No one is able to prevent.
Correct.
The most of the treatment is going in that direction. Is behind all the hospitals there will be a stem cell clinic.
So, sir, actually we can say that stem cells only help mouse. Am I right?
That also we do not know. We do not have any communication with the mice.
It can help
that is
you
only the animal lab. Animal lab.
You can't ask the mouse about activities of daily living.
Yes. Thank you, sir. So I hand over the mic to Dr. Maheshwari and Dr. Gagandeep.
Thank you,
Thank you
Dr. Achal. It's a nice presentation for the Parkinson's disease, as I am receiving that various messages from the physicians all over India. Now, I'm thanking you, Dr. Shyam Sundar, for giving the blessings, and also all the speakers, Dr. Charu, Dr. Rishikesh, Dr. Meenakshi Sundaram, Dr. Pramod Pal, for giving an excellent overview of the Parkinson's disease, because it was this topic was from the huge demand from the physicians, and now they are, because it will be on the YouTube, so now they'll be keep on seeing the things as an education material. And also thanks to Dr. Ravi and Dr. Sanjay for chairperson and nicely conducting moderation by Dr. Achal Srivastava. Now it's a end for this session. Maybe next month we are going to meet in some different topics. So thank you all. You're leaving. Okay.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you much.
Thank you. Thank you, everyone.
Thank you.
Thank you, guys, and please give your feedback so
Thank you,
that we
Nirmal.
can improve upon. Thank you, guys. Please give your feedback so that we can improve upon or add whatever has been suggested by you. Once again, thank you very much. We'll come forward to next month with another topic, another great speakers. So look out for your emailers for the next month's topic of Freedom Series. And I thank all the speakers and chairperson and Dr. Maheshwari and Gagandeep Singh for their initiation. Thank you. Have a good night.
Thank you.
Thank you, sir.